Good morning, Dr. Patino here at the Cosmetic Surgical Center of Rosarito. We're going to do micro air power assisted. You know what power assisted is? It's an electric tool similar to a toothbrush. So I go on and you can see it vibrating. And so we're going to go ahead and we're doing the inner thighs. We're doing a lot of areas on this patient, 360 basically plus the inner thighs. And the first thing you're going to see is what comes out of here, okay? And this is a special technique. So what do you see?
Yellow fat.
Yeah, Joanne, have you? For how long have you been a nurse, Joanne?
Many decades. Doctor.
Many decades. I want to know exactly how long.
Over 20 years.
20 years, okay. And have you seen liposuction before?
Many times.
Many times. And when you see a liposuction here, what do you see? What is the output?
I see nice yellow fat.
Nice yellow fat, right?
Yes.
Do you see any bleeding there?
No, I do not see any red or any evidence of bleeding.
Okay, and why would you see red?
Because there would be bleeding.
There will be bleeding. And when the liposuction that you've seen in your 20 years, is it yellow like this, or is it pink or red?
It is usually pink, and I have seen red.
Okay. So this is the first time that in 20 years you see yellow output like this?
That is correct, Dr. Patino.
Thank you. So Ahmad is our anesthesia provider, and Ahmad, you've been with us for a while, right?
Yep, 2 years now.
2 years already, right?
Yeah.
But you also have plenty of experience. You're an anesthesia provider. You've seen liposuction being done by other surgeons in other facilities many times, right?
Correct.
And what were you saying, Ahmad?
Well, I've seen all kinds of things, but when it comes to plastic surgery, normally I see when it's not done here at the Cosmetic Surgical Center of Rosarito, it's very bloody output with a little bit of fat, but then it's more bloody, almost looks like bright red blood. Here at the surgical center, it's predominantly golden yellow fat, with a tinge of blood sometimes, but mostly just yellow fat.
Thank you,
It's
sir.
the complete opposite.
Alrighty, so what color is that fat?
That's a bright yellow.
Wow.
Wow.
Incredible, yeah. And the nice thing is that we're doing a fat transfer to the buttocks. Joanne, have you done or have you been in surgeries where there is a fat transfer to the buttocks or no?
I have.
You have, okay. And when they inject the fat into the buttocks, what color is that fat when they put it in? What does it look like? Does it look yellow like this? Does it look pink? Does it look red?
It looks pink. It does not look yellow like yours.
Okay. So what that means is that when you put it in the buttocks, it's not pure fat. It is fat mixed with what?
Blood.
Yeah. Usually blood, right?
Yeah.
And so obviously the fat is not going to survive. I mean, it's not that the fat is not going to survive, but usually you lose about 50% of the volume that you put in, right?
Right.
Part of it because it's not pure blood. It's not pure fat. It's blood and fat. It's fat and blood. It's not like this, all fat, right?
Yeah.
So obviously, the volume is going to go down. It's going to look great the first week or two, and then it's going to reabsorb because the blood is going to reabsorb. In addition, the blood is irritating to the tissues, and it could be a factor of creating the famous blowout fractures that we never had. I believe it's a foreign body reaction, that the body reacts against your own blood that does not belong there. The blood belongs where? Inside the blood vessels, right? Not in the buttocks or anywhere else. And so a bloodless, oilless aspirate, and you inject a bloodless, oilless fat graft, then obviously it's all going to be retained. And obviously you're not going to have oil cysts either. Why? Because there's no oil. The oil is the result of traumatic, aggressive liposuction that breaks down the fat cells. But we don't do this here at the Cosmetic Surgical Center of Cerritos. Thank you. Okay, good morning. Dr. Patino here at the Cosmetic Surgical Center of Cerritos. So this is micro-assisted liposuction. And again, we're going to show you how to do this in a completely bloodless manner. So we're going into the abdomen now. We're going to do the inframammary area, the upper abdomen, the lower abdomen, the flank, the hip, the upper back, the subaxillary area. We already did the inner thighs, and we're going to do a fat transfer to the bottom. So it's a lot of surgery today, but look at the output right there. What do you see?
Gorgeous yellow fat coming
Gorgeous
through.
yellow fat, right?
Yeah.
So this is how we do it, and you may be wondering, well, how does he do that, right? So there is no secret here. It starts with the patient. So we tell the patient not to take any aspirin-like medications, no ibuprofen, no herbs, no vitamins of any kind for 2 weeks before and 2 weeks after the procedure. What does the surgeon does? The surgeon does not give any aspirin-like medications, no ibuprofen, no herbs, no vitamins of any kind. Some surgeons do routinely prescribe vitamins and aspirin and things like that. And on top of it, some surgeons give enoxaparin and heparin-like medications in order to minimize the risk of a blood clot, right? But the best way to minimize the risk of a blood clot is not blood thinners. It is early ambulation. But those surgeons that do that, they do it for good reason, and they're doing good, because a blood clot could be lethal, and that's actually common cause of death. And so thanks to God, we never had anybody die, and we want to keep it that way. But we operate differently, so we don't use any of those medications. We rely on early ambulation. The patient walks out of the operating room. So these patients, like you've seen them on TikTok, they walk out of the operating room, and some of you say, hey, let her rest. Because bed rest was recommended before, right? Now, no. We want the patients walking as soon as they get out of the operating room to prevent precisely a blood clot. So you need to pump the blood to return to the heart, because the venous return depends on the contracture of the muscles as you walk to be pumped. So you can do everything you want, but you can give all the heparin and all the enoxaparin, but if the patient is not walking, it's a setup for a blood clot. And of course, you got to do patient selection, right? You know, we don't operate on patients that have had a prior blood clot, or patients that are immediately in the postpartum period, because after you have a baby, that's the highest risk of blood clots, right? So we don't operate on patients that have systemic lupus erythematosus, or any patients that have a propensity for blood clotting disorder or bleeding disorder, right? So patient selection is key, but aside for that, the tumescent anesthesia is very important, right? And to tumescent in all planes, and to use epinephrine like we did. And the most important thing is to wait. See, we didn't even start this procedure for, I think, a good hour, right? So we let so we tumescent properly, and that's the thing that's very difficult for surgeons to do. They don't want to sit around. They tumescent usually very fast, 1 or 2 liters, and that's it. And so, then of course, there is going to be bleeding, but not only that, there will be also difficulty with pain, right? So our patients are straight up. You see the patient we operated on Monday, and she was on TikTok yesterday, right? Like nothing happened, straight up. We did a transumbilical breast augmentation with subpectoral silicone implants and a tummy tuck, and she's straight up, smiling like nothing happened. She looks healthy, walking like nothing happened, with zero pain. So yeah, what she's doing is she's preventing a blood clot. by walking. So our patients typically walk 1 mile the first day, 2 miles the second day, 3 miles the third day, preventing a blood clot. And so no enoxaparin is needed, no heparin, none of those medications if the patient can walk. But if the patient is in severe pain, and that patient is not going to walk, yeah, please do give him all those things, right? Because then you can get a blood clot. But if the patient has no pain or very minimal pain, and the patient is going to be walking, that's the best thing you can do to prevent a blood clot. Because, see, the arteries pump blood, right? It's a pulsatile fashion, right? But the veins don't have that capacity. They cannot pulsate, so they depend on the body movement, on walking. They depend on ambulation. And the earlier you ambulate out of the operating room, the better. So our patients just walk, right? That's what we want them to do. So we're doing high definition liposculpture here, and you can already see, maybe from that side not so much, but we'll see it later, no big deal. How we're creating this line, the athletic lines here, where the so those are key aspects of the surgery, and every surgeon knows about the tumescent anesthesia. This is a technique that is, there's nothing hidden here. But of course too, another thing that's very important is the speed of my strokes. So notice that my strokes are extremely slow. A lot slower than the typical surgeon, right? So as a result, then, it's like driving a car, right? If you go at full speed, there is going to be a moment where you may run into an accident. There's going to be a moment where you may go into an unintended area and perforate an organ. In this case, when these organ perforations happen, usually happen to a very tired surgeon that's been probably operating all day on a Friday afternoon and loses situational awareness, right? And so the same thing happens when you're driving, right? You may be driving tired, when you're driving at night, and then you lose control of the vehicle and go into an unintended area. So here is no different. If you're going at full speed, the surgeon may lose situational awareness and go inside the abdomen and perforate an organ, or go inside the thorax and perforate an intrathoracic organ, something that we never had. And we never had anybody die, but we don't operate on 10 or 13 patients a day, right? So yeah, you gotta also limit the amount of patients that you see per day so that you can see everybody. And I'm the only surgeon, so I don't rely on other surgeons to do my liposuction. I do it myself. And so look at this. What do you see?
I still see yellow fat.
I still see golden yellow fat. Thank you. All right, so I'm using my non-dominant hand. I'm ambidextrous. Most surgeons are ambidextrous, but even if you're not, you should try your non-dominant hand 50% of the time. That way, there is benefits for the patient, number one, and for you. So what are the benefits for the patient? It's going to force you to go slow. When you go slow, it's like driving a car. You go slow, less risk of an accident, right? And also, so much less risk of perforating an internal organ, right? Something that has never happened to us, right? But look how meticulous I am. My strokes are very, very controlled, very meticulous. The patient, because you have less risk of perforating an internal organ because you're forced to go slow, right? So that's important. Look at the color of that output. It's just almost like, gold, really. And not only that, but it's good for the surgeon too, because if you use both hands, then you're gonna decrease the risk of tendinitis, occupational injury, in the form of tendinitis to the wrist, the elbow, and or the shoulder. Thank you. All right, so notice how we're pretty much almost done with the procedure, right? And I want you to take a look at the fat over here with basically almost done with the procedure. And look at the beautiful fat that we're obtaining here. Yellow, gorgeous fat, right? Toward the end of the procedure, you guys, look at this. So this is just an incredible technique. We're gonna show you some photos momentarily. But look how, toward the end of the abdomen, basically high definition liposculpture of the abdomen, yet obtaining the most beautiful yellow fat aspirate. Once you show them the fat aspirate, we'll show them a photo later. But what I want them to see is how incredible this is. And this is a very unique technique, very incredible. But this time, this would be all full of blood, right? But yellow, beautiful aspirate here at the Cosmetic Surgery. I'm gonna show you the pinch test now. So let's see here, for example, look at this, see? Look at this. Huh? Look at this, huh?
Wow.
This is incredible, the pinch test, see? Incredible. Look at this side. Can you see on this side? Mm-hmm. Look at this. I'm lifting, and there's actually, we're down to 0.5 centimeters, you guys. Look at this. Unbelievable. 0.5 centimeters, and the pinch test. Thank you. Alrighty, so now we're doing ultrasound guided gluteal fat transfer according to the World Association of Gluteal Surgeons and guidelines. And notice how we're transferring this oil-less, bloodless fat graft. And I'm looking at the patient, I'm looking at what's going in, I'm looking at the ultrasound, and we want to put this in the deep subcutaneous space. We're covering a large tattoo over here for social media, but the main thing is look at that fat graft, like I told you, and this fat graft has not been treated in any way. This is how it came out, you saw it come out, and this is how it's going to go in. Bloodless, oilless fat graft. Incredible. So this is going to contribute to much greater fat graft retention. Thank you. There is 3 compartments on the lateral side, 3 compartments on the medial side, and 1 large central compartment. So I use that superior gluteal incision to go into these 3 lateral compartments exclusively. And we're doing it under ultrasound guidance according to the World Association of Gluteal Surgeons guidelines into the deep subcutaneous space, which is where these compartments are.
The patient's skin. This is the superficial gluteal fascia. This is Dr. Patino's cannula. He's going to wiggle it for us. And then this is the deep gluteal fascia. And what you can see right here beautifully is the striated muscle, right, doctor?
Yes, it's a beautiful image. And so what I'm going to do now is I'm going to advance it a little bit. And I'm going to point to the tip of that cannula, okay? And then we're going to give it a bolus. So you're going to see a gray cloud as I inject the fat, okay? And then tell me what's going to happen when I inject the fat.
So in a moment, he's going to give us that bolus of fat. And what we're going to notice is as it enters this deep subcutaneous space, we're going to see that the deep gluteal fascia is going to get pushed down from the pressure, and the superficial will get pushed up just a little bit.
Yeah, okay. Very good. So here is your cannula, okay? And I'm going to withdraw it just a bit. And you see the tip of that cannula right there, right?
Mm-hmm.
Point to the tip of the cannula,
Okay.
And 1, 2, 3, pay attention to the tip of the cannula there.
Alright, so here we have the bolus of fat entering the space. And see how that deep gluteal fascia is getting pushed down? As fat enters this deep subcutaneous space, that's what we see right here. See, it's getting pushed down. It was up here, and now it's kind of getting closer to maybe 3 centimeters now. And so the space has become, it's accommodated the fat.
Yeah, and so now I injected the fat as I withdrew under ultrasound guidance. What I want to show you is that I'm right here in the deep subcutaneous space. In other words, between the superficial gluteal fascia and the deep, which is up there. And that space is the superficial subcutaneous space. Now, this space here that was described with the 7 compartments by Dr. Daniel Del Vecchio shows that in the central compartment, which is where I'm at, the fat slides, is redistributed very, very easily. So you can put a bolus of fat here, and then it will equalize. It will basically move around pretty much even on its own. You could do one buttock, move to the next buttock, and you'll see like a bump here. And then when you move to the next buttock, it will equalize because the fat freely move within this compartment, the deep subcutaneous space compartments, correct? But if you go more superficial, into the superficial subcutaneous space, there is more fibrous tissue there and it's not as compliant. So any fat graft that you put in there may give you that characteristic peau d'orange, and it is not going to move as easily. So my theory about this is that it has been taught that you put the fat and the fat migrates into the other compartments, and that's okay. But what I believe happens also is that through pre-tunneling, which I do not do, this fascia here, the superficial, you inject the fat in here and there is pressure, potentially the fat in the deep subcutaneous space is going to leak into the superficial subcutaneous space, and because this space is not that compliant, if I would, it may blow out into the skin, into the area of less resistance. And I think that that's what's happening. And if you were, for example, to follow my cannula right there, and I keep going, I'm eventually going to perforate this superficial gluteal fascia, and the fat that I put in the deep subcutaneous space is going to herniate out and give you a blowout. That is my theory. Thank you.